here. So because this series we have some repeated questions, because at the end when we will have sum up session, what is our idea? So maybe at that time our one of moderator, so he will ask, so GERD and MGB, okay, GERD before surgery and MGB. So then we will have clips of these legends. So then, yes, what was the opinion of Professor Osama? What was the opinion of Professor Robert Rutledge, Laurent Layani, Lee? Okay, this will be some obsession. So same hiatal hernia and this, and also if every question due to this, we have some repeated question, and now we are going to complication, and also we will discuss revisional surgeries in MGB. But because due to this we have a routine, and also this is an interview. First of all, sir, we want to know your brief introduction, please.
Sure. Can I share my screen now?
Sure, sir, please.
You see the slides right now?
Yeah, I can see, sir.
Perfect. So regarding one anastomosis gastric bypass, I will try to answer all the questions, Imran, and please feel free just to stop me anytime to ask any questions. Actually, one anastomosis gastric bypass becoming much more popular with time. We began this procedure in 2008, 2009, and we have exceeded more than 4,000 cases now of one anastomosis gastric bypass. And we have a vast experience, me and my team, in such a procedure. And all the favor goes back to Dr. Rutledge for sure, the inventor of one anastomosis gastric bypass. And I would like to share my experience regarding one anastomosis gastric bypass. We'll begin with a video just to grab them some attentions. Actually, I always begin with my left hand, dissecting the angle of Hess. We always like to identify the angle of Hess first, because we believe that with one anastomosis gastric bypass, it should be a good, tight, long pouch, and always trying to create longer pouch. Longer pouch is better than shorter pouches in one anastomosis gastric bypass. Sometimes it's becoming very challenging in some stomachs, like the G-shaped stomachs, to create longer pouch. Yet we always do that way. This is our technique in doing the pouch. It's an edited video for sure. This is a long narrow pouch on a 36 French bougie. We clear the posterior wall of the stomach, and we believe in the restrictive part of this procedure. So the pouch should be uniform, unipressure, long pouch, and we do always the anastomosis. We do the gastrostomy through the staple line, because it's the easiest place to do the gastrostomy. All the layers is, and then we rotate and we count clockwise, and we always use this historical stapler. It's called a multifier from Medtronic. It's only 3 centimeters. We do a linear posterior wall anastomosis, and we do the anterior wall with a Vicar 3.0 by that way. So this is a quick video, and we have detailed videos for sure for such procedure. If anyone wants a version of our video, we can just send it on the email or send it through Facebook. For the sake of time, I just edit it just to see. And we always take a serosal layer from the intestine and a full layer from the stomach. And we like both stitches to cross each other we take two-stage sutures and we cross each other to secure the anastomosis. And with such technique of the anastomosis, actually, we don't have any problems or kinking or twists. And then we take an antiprostatic suture, and I coop the inventor in antiprostatic stitch and carbajo. We do only one single stitch just to alleviate the stress on the anastomosis, and we don't think actually that this has anything to do with the reflux post-operatively. So before, during our learning curve, and then we do the test, we were hanging the loop up and take a continuous sutures till the first key stitch. Right now we take only one stitch and that's it. So we'll talk about the main concerns after the honest most gastric. Do you have any questions, Imran, about the
Yeah,
procedure?
sure, sir. This is excellent. And also in this video, you have showed you are also this technique and how this is a mixture of anastomosis, gastric bypass, and MGB that always Rutledge so ask MGB original technique OT, and also that is the anastomosis gastric bypass by Carbajo, and most of surgeons that now I have interviewed, they have something from Rutledge, and as well as some points or some tips from anastomosis gastric bypass. Why not, sir? So already you have already we see this video of your technique. What is my question? So you have started as earlier you have mentioned now. So in learning curve, yes, there was 2 layer. This when you stitch this or close this enterostomy or that stapler side or gastrotomy. So yes, two layer, but now you prefer 1 layer. So have you changed any other technique uh, for this procedure MGB OAGB when you have started for better results like length of pouch, size of, because your size of this gastrojejunostomy was just like 3 centimeter. Have you changed, and why you have changed?
Actually, when we began this, we have 15 to 18 years of experience in bariatric surgery, and we were Roux-en-Y gastric bypass surgeons before the sleeve era comes. So actually, my learning curve in the Roux-en-Y gastric bypass affects my technique in one anastomosis gastric bypass. So this is the way that I do my gastrojejunostomy in Roux-en-Y gastric bypass, and I don't have any problems. So we adopt the same technique in the anastomosis, and we believe in restrictive element of malabsorptive procedures. So what you have seen now is a mixture of one anastomosis gastric bypass and MGP. We began with 45 millimeter stapler, and right now we do only 3 centimeter stapler because the weight of the loops is so heavy. So in reduced surgery, after 2, 3, 4, 5, 6 years of one anastomosis gastric bypass and Roux-en-Y as well, we found that this anastomosis takes the posterior wall and comes down. So the stoma becoming wider. That's why we go smaller for a smaller diameter of staplers than the 45. So now we use only 3 centimeters from the staple. Either we do this, we use this stapler, or we use the ETS from Johnson & Johnson, or you can use the 6 centimeters and take only 3 centimeters of it, which enhance the restrictive element of one anastomosis gastric bypass, which affects as well the weight loss of the patients. And for sure, we have to dissect the angle of Hess very well. We have to exclude the fundus very well. So we believe that long narrow pouch with one anastomosis gastric bypass with a 3 centimeters diameter linear stapler anastomosis uh, gives us the best results regarding this.
Sir, so regarding this, because now we have, in my opinion, followers thousands of surgeons and also especially youngsters. So they are follow especially this interview. So what is my question? So as you mentioned, progressively this stoma become large. Progressively, I agree with you. So in your experience, what happened? So after some time patient was suffering with dumping or weight regain. Due to this, you decrease the size.
Actually, no, we don't have an issue in dumping syndrome after one stenosis gastric bypass. And when you review the literature, you will find a very few studies talking about dumping after one stenosis gastric bypass. Actually, dumping after one Y gastric bypass has a higher incidence than the one stenosis gastric bypass. This does not mean that it happens. It happens with a very less percentage than the Roan Y gastric bypass. So what we have done actually has nothing to do with dumping. It has something to do with the long-term effect of the one stenosis gastric bypass. And I will talk also about the weight regain after one stenosis gastric bypass and what we do after one stenosis gastric bypass. And to be clear for the youngsters, actually, if you are planning to do one stenosis gastric bypass, you have to know very well how to convert it to Roan Y. Roan Y is the golden standard. I will want to jump to conclusions, yet we will take the slides step by step. Roan Y is the golden standard and still the golden standard of bariatric surgery. And almost 90% of the problems of the one stenosis gastric bypass or sleeves uh, can be treated by Roan Y gastric bypass. So when you jump into the one stenosis gastric bypass, you have to know how to dismantle it, you have to know how to reverse it, and you have to know how to convert it to Roan Y gastric bypass. Because in these three options are the total solutions after any problem in bariatric surgery following one stenosis gastric bypass. So you have to have a vast experience and a good experience in how to use this tool, which I said, I'm always considering our procedures are tools, either to use it or to lose it for the patients. So to use this tool as one stenosis gastric bypass, you have to know how to handle its complications, how to handle the reflux that may happen after, have to handle if you have a leak, if you have a weight regain, if you have anything to do. So you have to know how to reverse it, how to convert it to Roan Y. You have to know how will you deal with it and with its problems.
Sir, in your video, you also mention here, and also because regarding this his angle dissection, that is your first step in one anastomosis, gastric bypass. So, if you find any hiatal hernia uh, during this dissection, what you will do? You will repair any standard, any criteria for this. How much it will be? You will repair if you
If
repair.
we have actually if we have a hiatal hernia that has been diagnosed before surgery, so if it's more than 3 to 4 centimeters and if it's symptomatic, we will repair it. We will do posterior chloroplasty and we deliver it down and do a posterior chloroplasty and then do one anastomosis gastric bypass or Roan Y. I don't believe that you can do a one anastomosis gastric bypass and just ignore the hiatal hernia if you see it. As surgeons, as upper GI surgeons, we don't have to ignore any hiatal hernias, even if you are going to do a Roan Y gastric bypass. If you discover a hiatal hernia, you have to fix it because we are basically not bariatric surgeons. We consider ourselves as upper GI surgeons. So if you have a hiatal hernia, you have to repair it very well by posterior chloroplasty. And then you can go for one anastomosis gastric bypass or Roan Y gastric bypass. I don't believe in crural repair and sleeve gastrectomy, yet I believe in crural repair and gastric bypass, whatever gastric bypass will be.
So, sir, just question because you have lot of experience. So, in your this about 2 decades experience of bariatric surgery, so have you did any one anastomosis or Roux-en-Y, because you are also talking about Roux-en-Y gastric bypass, especially one anastomosis gastric bypass in a case with large size hiatal hernia and the condition become worse after surgery without repairing this crura?
Actually, in my experience, I do a posterior cruroplasty, and I prefer to go for Roux-en-Y gastric bypass rather than one anastomosis gastric bypass. Even in our consent here, if you ask about the medical legality, we let the patient sign for a gastric bypass, either one anastomosis gastric bypass or the Roux-en-Y, and we take the decision inside. So if we have a large hiatal hernia and we are going to do a cruroplasty and a repair, we prefer to go for Roux-en-Y gastric bypass, a distal one with a longer PPL length, rather than doing one anastomosis gastric bypass.
Excellent. Sir, regarding this, because you know better than me, so the main concern of MGB, OAGB is bile reflux, bile gastritis, and marginal ulcer. And also, this has been mentioned by so one of the legend, Di Maria, as well. So previous procedures of Rutledge. In 2021, after these variations, this technique, everything, still this is concern.
Yes, it's a big concern. And we cannot say, we have to be sensible surgeons, if I can say, run. Sensibility to not be, I'm so sorry for, with all respect to everyone, to not be biased to one procedure, because we are bariatric surgeons. So we do duodenal stretch, we do SADIs, we do Roux-en-Y, we do one anastomosis gastric bypass, we do sleeves. So you have to put in your pocket more than 3 to 4 solutions for the patients. If you do only one anastomosis gastric bypass and sleeves, so you will not be able to judge on the other modalities. So yes, it is a concern. I'm so obvious in this. It is a concern. Reflux is a concern after one anastomosis gastric bypass. We have some patients with intractable reflux, and we have some patients, and we are running now a study. I will share some slides of it about gastroesophageal reflux for one anastomosis gastric bypass, especially if you use the one anastomosis gastric bypass as a redo surgery after failed restrictive procedures. So when we do one anastomosis gastric bypass after failed bands or failed VBGs, if you are able to do a longer narrow pouch in the VBG, we have some problems with reflux. So actually, in the last 2-3 years, we have changed our practice a little bit. That any patient with failed restrictive procedure, we go for a longer PPL limb, Roux-en-Y gastric bypass rather than one anastomosis gastric bypass.
Sir,
And we have some videos also for marginal ulceration. Actually, it's not significantly different, the incidence of marginal ulceration versus in one anastomosis versus Roux-en-Y. Yet I have made a video with marginal ulcer that I have reversed the one anastomosis gastric bypass, and we have done also, we undid the anastomosis and we excised the marginal ulcer, and we do Roux-en-Y gastric bypass in some other patients. So actually we faced everything.
sir, we will.
And that's why you have to.
Sure, we will also discuss about this in detail. So please, sir, this is interesting in my opinion. This outcome of omega loop gastric bypass. Your 6-year experience in 1,520 cases. Please, sir.
Yeah, we have published this in 2017, actually, our outcomes and the diabetes remission, actually. And when you see the excess weight loss, it goes up to 78.9%. So it's really a very good procedure as one anastomosis gastric bypass in weight loss and also in diabetes remission. And actually, right now we have involved the rest of the 4,000 cases, and actually numbers did not differ. We reached to 79.7.9% in 2 years, and 5.7 of hemoglobin A1C. So there is some here, if you can see here, there is some weight regain happens after 2 years, yet it's still a very excellent results actually. Regarding our early complication rate, as you see here, it is not that high numbers, 3.2%, which is comparable to Lee, Kolar, Carbajo, and other large studies. The main issue is the abdominal bleeding. So I always recommend the youngsters to take care of abdominal bleeding. Don't take it lightly, and please go for a second look if you have any problem rather than doing conservative methods. And sometimes it happens also a jejunal perforation when you count the whole intestine. If you are counting the whole intestine and take only 30%, you have to focus on this and take care, because you may perforate the jejunal or the small intestinal loops without knowing this. And that's why when we do that, I will jump to the technicality once again. When you do the test, you always release the pancreatic limb before releasing the alimentary limb, just to divert the methylene blue toward the proximal intestine, where you count once or twice. And if we jump to the late post-operative complications, as you see, is the anastomotic, our rate of anastomotic ulcers is 0.3%, and our rate of intractable reflux is about 1%, 41 patients out of the 4,000. So between November 2009 and December 2015, we underwent 4,000 one anastomosis gastric bypass, 1,400 were diabetic, 968 has been included in our study regarding the evolution of hemoglobin A1C after one anastomosis gastric bypass. As you see here, the mean of hemoglobin A1C is going down from 9.6 to 5.8 in 36 months. So we believe that one anastomosis gastric bypass is really a very good procedure, a metabolic procedure for diabetes. If we compare the remission rate of our group of patients, we find that a complete remission happens in more than 84%. Partial remissions means that hemoglobin A1C is between 6 and 6.5 and 7.8%, and improving of the disease has happened in about 7%. No improvement in 1.1%. So we have a very good percentage of diabetes remission after one anastomosis gastric bypass. And we actually tried to have some predictive measures regarding number of drugs and if the patient goes for single oral drug, 2 oral drugs, or 3 oral drugs, we found that as early as possible, if you intervene and did the one anastomosis gastric bypass in patients with a single oral drug, you will have a better single or double oral drugs. You will have a better recovery and remission of diabetes mellitus, rather than staying and neglecting the diabetes till 3 oral drugs or insulin injection. And as we see here, regarding the change of hemoglobin A1C in different BMI groups, so we studied also the rate of remission comparing with the body mass index preoperatively, and we didn't find any significant difference here. So when we compare the weight loss of one anastomosis gastric bypass in our patients group, comparing with the largest series published, like Lee, Mosella, Kolar, and Gwanzi, and Arabi, we found that it's very comparable together, and regarding body mass index and weight loss, as you see in this table. When we compare our one anastomosis gastric bypass in comparison to the sleeve gastrectomies and Roux-en-Y gastric bypass in our unit, we will find that one anastomosis gastric bypass is comparable to Roux-en-Y gastric bypass in leak percentage, In abdominal bleeding, it's really a very good option. In marginal ulceration is less than the Roux-en-Y gastric bypass, and we don't have enough clarification for this. And regarding even gastroesophageal reflux disease, the winner here is the sleeve gastrectomy, and then the Roux-en-Y, then the one has the most gastric bypass. And I want to stop here for a while. If you have a reflux issue after one anastomosis gastric bypass or sleeve gastrectomy, you can convert it to Roux-en-Y gastric bypass. Yet we have some intractable reflux after Roux-en-Y gastric bypass, which is really weird. And it's underestimated in the literature, and it's not studied very well in the literature. So we have some intractable reflux, and we have excluded gastrogastric fistula, we have excluded kinks, and we have excluded everything, and we still have some patients with intractable reflux after Roux-en-Y gastric bypass. And we have done everything. We done distalization, we wrapped the remnant stomach, and it doesn't work. And actually, every time I evoke these questions, I don't have any enough answers from the experienced surgeons or in the literature, because I believe that it's an underestimated problem regarding Roux-en-Y gastric bypass. If you have a reflux after Roux-en-Y gastric bypass, what should you do? You can come in and see that the pouch is not that big and your parameters is fine and everything is fine, and then nothing happens. And if you try distalization, if you try a remnant stomach fundoplication, you will not have a satisfactory results. So I would like to hear from you, Imran, if you have any experience of Roux-en-Y gastric bypass suffering from reflux.
Yeah, sir, sure. So this is challenge. I understand. Yes, because in 2008 I have started Roux-en-Y gastric bypass, and yes, we have faced such a situation. Really, it is a challenge. So when you have such a case, so and no response to PPI, no response to sucralfate, no response to medication. So someone they do so some chloroplasty, maybe there is a hiatal failure, but again patient is suffering. And I remember one case, you can't believe, we did complete gastrectomy for the case, and at the end esophagojejunostomy. Unfortunately, I remember one case, and because there was no response, nothing, then we have changed to so this complete gastrectomy and esophagojejunostomy, and then it was okay. Sir, we will continue our interview, and because we have also many questions from Facebook, so you can stop your sharing, then they can see you. You can stop
Sure.
here.
Yeah, sure.
Then
Should I stop my sharing?
yeah, because your fans and your followers see you in your in complete.
Yeah, sure, sure. I'm fine.
Sir,
I'm fine with this.
you have mentioned because this interview, what we try a little different than webinar, in light mood, you relax, and also you will share your knowledge and your experience. You have mentioned in your presentation GERD and marginal ulcer that was less than Roux-en-Y as you compare.
Yes,
Yes. So what is my question? So in just we can, so a patient with symptomatic with documented reflux, also symptoms, also document with the endoscope. Yes, you recommend. Yes,
yes, yes.
yes, the reflux. Are you go for one anastomosis gastric bypass?
No, clear no. I do a Roux-en-Y gastric bypass.
Sir, your what is your now you went to share this experience. So GERD is less than Roux-en-Y gastric bypass. Have
Yes,
have
yes,
you bitter experience? Banana stomach.
yes. Actually, there is a complete difference between symptomatic GERD and a diagnosed GERD, if you agree with me.
Yeah.
So with symptomatic GERD, we do our own Y gastric bypass because we have enough evidence in the literature about the Y gastric bypass, because we stick to science here. We do not stick to our results and our series also only. Our guidance is the science and the literature and the publications. So we have less problems with one anastomosis gastric bypass regarding internal hernias, regarding GERD, regarding in the de novo cases. I want also to come back to my slides and share the revisional cases of one anastomosis gastric bypass versus Roux-en-Y to just to clarify this point. Yet there is enough evidences in the literature that saying that Roux-en-Y gastric bypass is very good for GERD. And in our experience, yes, with symptomatic cases, Roux-en-Y gastric bypass wins. Actually, when the patient comes symptomatic to us, we cannot offer a one anastomosis gastric bypass because there is no enough evidence, strong evidences in the literature or randomized trials to comparing the reflux of one anastomosis gastric bypass versus Roux-en-Y gastric bypass. So my message here for all the youngsters that please stick to science, stick to literature, stick to the publications, and try your best to find the strong impacted researches to guide you through your practice, not only your experience. I cannot I cannot depend on my series only because all the legendary surgeons all around the world has a lot of experience, maybe more than us 1,000 times. So we have to respect the science. We have to respect the literature. So if we have a symptomatic reflux, we go for Roux-en-Y gastric bypass. If it's not symptomatic reflux, actually, we can do a one anastomosis gastric bypass. Yet the problem is not the one anastomosis gastric bypass versus the Roux-en-Y. The problem, when the reflux happens after the surgery, what will you do? I think this is the main question here, Amran. If you have a one anastomosis gastric bypass with the symptomatic reflux patients after the surgery by 18 months or 20 months, you can convert it, dismantle it, you can reverse it, you can do a fundoplication, you can do a lot of things. If you have a problem with symptomatic reflux after Roux-en-Y gastric bypass, you run out of options. This is the problem.
Sir, excellent. Sir, regarding this, so this is this pre-op endoscopy and H. pylori detection or eradication is your routine practice?
It's not a routine, it's in symptomatic patients only.
And in post-op, one anastomosis gastric bypass, endoscopy is routine or no? Only in
Yes, we do it on yearly basis, yet not all the patients becoming very cooperative regarding endoscopy every 6 months or every year, because we are working on a private setup and a public governmental university. So cost is an issue. And at the same time, you cannot obligate the patient to do a routine endoscopy after the surgery. So we like to do a routine endoscopy every 6 months, every year, every 2 years. Yet we have a problem in the discipline of patients after surgery to do this endoscopy and to push them to do the endoscopy every year.
sir, in
So we
endoscopy,
cannot do it for everyone, yet we do it for symptomatic patients.
sir, in a selected case, when you do pre-op endoscopy and you confirm H. pylori, are you
Yes.
eradicated before surgery?
Yes, we have to eradicate it for at least 3 weeks, and then we do another endoscopy and take another and do another lab work and be very sure that H. pylori is negative, and then we do the procedure, either whatever bariatric procedure.
Sir, other than reflux, because already we have talked about reflux, and yes, you exclude anastomosis, gastric bypass. Which gastric finding? I am talking about gastric finding. Any pre-op endoscopy, which gastric finding so for you is relative contraindication for one anastomosis gastric bypass? You will not go like there is a bile gastritis in
If you do a preoperative endoscopy,
pre-op endoscopy in a selected case, which finding so you are worried, yes, maybe patient will be like this bile gastritis, so we can see bile gastritis, or no, you treat this bile gastritis, then you will go for one anastomosis gastric bypass.
there is no enough answer here, Imran. We have done thousands of endoscopy, and you find bile in the stomach, and this is normal,
Yeah,
right?
yeah.
To find bile in the stomach, in a de novo stomach, it's normal. So you cannot avoid doing one anastomosis gastric bypass because you find some bile in the stomach. So, and actually, you can do a manometry and pH metry in patients with symptomatic reflux, and you find. Imran,
Yeah,
are
sir.
you
Yeah,
hearing
sir.
me?
Yeah, little. I think there was connection issue. Sir, another question. So, about I know maybe there will be no definite because people want to know because these are hot topics, especially this endoscopy after one anastomosis, gastric bypass. What is my question? Which percentage that you asked me already? You have told so symptomatic patients, 20%, 30%. What is the percentage of this patients who did endoscopy after one anastomosis, gastric bypass, and what was the findings? You find any
It
asymptomatic
is.
like marginal
It
ulcer?
is. It is. I can say it's about 2 to 3%,
Yes.
and you can do an endoscopy after one anastomosis gastric bypass, and you find nothing. And you can do a pH metry and manometry, and you find nothing. And at the same time, the patient is suffering from symptomatic reflux. So it is, as I said before, it is an underestimated issue in the literature, and I'm used to take the complaint of the patients very seriously here.
Sir, regarding tailored DP limb, so that is again a issue. Also in initial and also redo
Sure.
surgeries. So have you changed your practice? Have you decreased this BP limb after facing any malnutrition?
Yes, after after the last study of Ammo, when he figured out that 250 is not that differ in body mass index reduction comparing with 180 centimeter, we get down from 250 to 200, 170, 180 centimeter of BBL limp. Yes.
Sir, sir, another question regarding GATE because we will go ahead also for redo and also we will watch also your slides and your presentation. What is my question? You have mentioned so you had some also detectable reflux, also you faced GATE. So what is my question? If you compare when you have started earlier this MGB, OAGB, so if you compare your practice, your own patient with 2019, 2020, and 2010. So if you compare this guild after surgery with the passage of time, when you change your technique, the size of this pouch, everything, because we learn every day and we change our practice. Definitely, we change our practice. Also, size of this gastrojejunostomy. Do you think now guild is less than your earlier patients?
Actually, in my opinion, it's not related to the technical issue. It's related to the multidisciplinary team. For sure, now we have less problems than before because you learn more and more,
Yeah,
and you may modify your technique without you feel even.
yeah.
You find your one of the most gastric bypass or your bariatric surgery practice becoming more clear and more organized than before. So with a multidisciplinary team, with a proper nutritionist and with the proper lifestyle coaches and with a proper follow-up, you'll find less and less problems regarding, not regarding reflux only, regarding reflux, regarding any late complications after bariatric surgery. So yet, if we compare it technically, actually when we minimize the stoma to 3 centimeters, I think that, and we do a very straight monopressure longer pouch, I think that the reflux is becoming less. Yet we don't have enough clue about this. I think that we follow the patients very well. We chase the patient everywhere, and maybe that's why we have less problems. And when we conserve the patients and do the medication as early as possible, I think we avoid a lot of problems lately.
Sir, excellent. Regarding PPI, what is your opinion? So, how long time you prefer and which dose for your patient after one anastomosis?
Actually, I'm giving PPIs 40 milligram a single dose per day for 6 weeks.
Excellent.
And then I'm always instruct my patients to have it in their cupboard just to take it when needed.
Excellent.
Yet we don't prolong it after 6 weeks. No.
Sir, sir, please you continue your slides so we will watch. So, please, sir. Then maybe some question, and also you have lot of question on Facebook. So I must share with you.
More than welcome.
Yeah, please, sir.
Yeah. Regarding the comparison between one anastomosis gastric bypass and the Roux-en-Y, so regarding weight loss, the BBL length actually is something that we have learned from one anastomosis gastric bypass. Even we modified the Roux-en-Y gastric bypass all over the world now. And this is a lesson which should not be underestimated after doing a single or a one anastomosis gastric bypass. Actually, we all knew now that the magic happens in the biliopancreatic limb, not the alimentary limb like before. Because I'm the student, my mentor is Hans Lundroth. He's the inventor of anti-colic, anti-gastric, Roux-en-Y gastric bypass in Sweden, and we have done thousands of Roux-en-Y gastric bypass with 20 to 50 centimeters PPL length. Right now, we do the Roux-en-Y gastric bypass with 200 and 170 and 150 BBL length, and this is the lesson that we have been taught from one anastomosis gastric bypass. So if we compare the patients with revisional surgery or conversion to Roux-en-Y gastric bypass when NOON excluded, we found that we have a very good weight loss after Roux-en-Y gastric bypass. And even after one anastomosis gastric bypass in 6 years experience of more than 10,000 patients in Kular, we have a very excellent excess weight loss percentage. And actually, even in our study, the mean excess weight loss is really good in 6 months to 2 years. And when Musella in 2014, comparing the outcomes of 974 consecutive cases in multi-centric review, the percentage of excess weight loss in 5 years were really significant after one anastomosis gastric bypass. And when Lee compared the Roux-en-Y gastric bypass versus the one anastomosis gastric bypass after 10 years experience, which is a very strong paper, I really congratulate him for such a publication. We found that weight loss in one anastomosis gastric bypass is higher and superior than the Roux-en-Y gastric bypass. And also in this meta-analysis 2018, I recommend all the youngsters to read this meta-analysis. It's really good. We found that excess weight loss in 2 years after mini gastric bypass versus Roux-en-Y gastric bypass, as you see here, if you see here that mini gastric bypass is higher in weight loss than the Roux-en-Y gastric bypass even after 2 years. And for a longer follow-up is recommended here, yet the initial numbers in 2 years is really promising after one anastomosis gastric bypass. Regarding evolution of hemoglobin A1C and remission of diabetes, we found no significant difference. This is our series, actually. This is our study from 9.6 to 5.8 in 36 months, as I shared this before. And when we compare the diabetes remission in our series versus Lee, Musella, Kolar, and Gwenzi, we found it comparably to the other studies. So when we compare Lee, when he compared one anastomosis gastric bypass versus sleeve gastrectomy, we found that one anastomosis gastric bypass is higher in body mass index reduction and hemoglobin A1C reduction and remission of diabetes in one anastomosis gastric bypass when it's compared to versus to sleeve gastrectomy. And as you see here also, when you compare the mini gastric bypass to Roux-en-Y gastric bypass, we found a higher metabolic impact of one anastomosis gastric bypass versus Roux-en-Y gastric bypass, as you see in diabetes and hypertension. And also in the same paper of Lee in 2014, we found that remission of diabetes when you compare the one anastomosis gastric bypass versus sleeve gastrectomy, one anastomosis gastric bypass wins, as you see, in hypertension and diabetes. So our early complications was about 3.2% in our series, as documented in our literature, and it's comparable also to the other studies that has been published. I will go through this very quickly to go for the GERD and the revisional one anastomosis gastric bypass. And as you see here, we have 18 patients out of our group, 1.2%, with intractable reflux and patients with anastomotic ulcers, a total 6.1% early and late complications in our series. And it is also comparable to Cholera at about 9%, and Musella is about 9% as well. We have a very good operative time with our technique, and we have a complication of 6.1%. 1.1% out of 6.1% needs surgical repair, and we have one patient's mortality, which is compared to other patients, other series. So when Lee compared mini gastric bypass with Roux-en-Y gastric bypass, actually, regarding body mass index and weight loss and hemoglobin A1C, one anastomosis gastric bypass significantly higher and winner than the Roux-en-Y gastric bypass regarding body weight and metabolic procedures. Also in late complications like bowel obstruction or major bleedings or post-operative fluids passage, intraoperative blood loss, mini gastric bypass has a better outcome than the Roux-en-Y gastric bypass. So we believe that one anastomosis gastric bypass seems to be simple, safe, and effective. Also to appear to have acceptable complication mortality. Most of the literature data show that the one anastomosis gastric bypass has the ability to be an excellent alternative to Roux-en-Y gastric bypass with significant lower internal hernia rate and better weight loss achievement. So we'll go through the revisions actually, and this is a very interesting thing for the bariatric surgeons actually. From May 2009 to December 2015, a total of 543 patients with failed restrictive bariatric operations underwent laparoscopic revisional bypass surgery by our team. 348 of them were feasible for 2 years follow-up and included in this study. And 243 patients underwent one anastomosis gastric bypass as revisional surgery, and 105 underwent Roux-en-Y gastric bypass as a revisional surgery. Among them, 203 were failed after vertical banded gastroplasty, 95 were after adjustable gastric banding, and 50 patients after vertical sleeve gastrectomy. And these are the demographic data of the patients, as you see here. So as you see here, these are the group of single anastomosis gastric bypass, and these are the group of Roux-en-Y gastric bypass. So when we talk about the intractable reflux in redo surgery, this is really very important. As you see here, we have a very high rate of reflux in redo surgeries doing one anastomosis gastric bypass after failed restrictive procedure rather than doing Roux-en-Y gastric bypass. And this is what I was talking about, Imran. So when you have a failed restrictive procedure, you have to think and study the patient very well before you do a one anastomosis gastric bypass. So you can, I think, safely do you may do a Roux-en-Y gastric bypass rather than doing one anastomosis gastric bypass, because we face a lot of problems in patients after failed restrictive procedures. And maybe because the restrictive procedures destroy the esophagogastric junction and make make the stomach a little bit, and the esophagogastric junction is a little bit incompetent, and you could not diagnose it through endoscopy or something like this. We have a very high rate of intractable reflux in redo surgeries using one anastomosis gastric bypass. So we use the SS questionnaires, if you are familiar with, as you see. And the GERD questionnaire is using a grading of symptoms of heartburn and regurgitation. A severe score is more than or equal 4 is considered positive for GERD. It's a validated questionnaire from Carlson 1998. And when you compare each other, as you see here, you will find that patients with a score 4 or more is higher in the group of one anastomosis gastric bypass as a revisional surgery rather than in Roux-en-Y gastric bypass as a revisional surgery. And it's significantly higher in one anastomosis gastric bypass than the Roux-en-Y gastric bypass. So when we compare it with each procedure, so using the single anastomosis gastric bypass after VBG, we have the highest actually. We have the highest. The highest reflux happenings if you do a one anastomosis gastric bypass after VBG, and less after bands and lesser after sleeves. As you see here, a total number. So doing one anastomosis gastric bypass after VBGs, after you remove the mesh and you go down and you create a longer pouch, I think that it's not in our practice. I can say it's not recommended. Maybe it could be acceptable after adjustable gastric banding or sleeve gastrectomies. So as you see here, if you use it after vertical banding gastroplasty, you have the highest percentage, and you do it after adjustable gastric banding and sleeve gastrectomy, you have lower percentage, yet you have a high percentage at the end. And when we return back to our data and see that actually all the symptoms happening after 4 to 6 months from surgery. So patients was very well for 4 to 6 months, and then suddenly evoked a reflux, maybe intractable, maybe symptomatic, and actually the symptoms aggravate with time, not relieved even with medical treatment. As you see here, the winner is after vertical banded gastroplasty. It becomes very high intractable reflux when you use a one anastomosis gastric bypass in case you have tailored a longer pouch. And it's acceptable after sleeve gastrectomy, yet I don't think that it's acceptable after after VBGs and bands, as you see here in this graph. So Lee also compared this actually, and we found it a very underestimated topic in the literature. And we found very few studies that talking about revisional mini gastric bypass comparing primary and revisional mini gastric bypass. And as you see here, stomal ulcers is less in revisional mini gastric bypass, yet bireflux in Lee series is higher in revisional mini gastric bypass comparing with a primary mini gastric bypass. Go through this. This is how we do the Roux-en-Y. So, and we can do this while we are discussing. So we believe that most of the literature studies reported low incidence of reflux and significant difference in gastrointestinal quality of life, and less symptoms of heartburn, regurgitation between or similar symptoms between one anastomosis gastric bypass and Roux-en-Y. Although revisional surgery using one anastomosis gastric bypass has a better weight loss than Roux-en-Y gastric bypass, it has a higher chance of reflux and anemia in long-term follow-up. Regarding the reflux issue, the revisional surgeries using one osmotic gastric bypass may be not the ideal procedures after VBGs or adjustable gastric banding, or and may be acceptable after sleeve gastrectomy. So before I jump to the weight regain, do you have any questions
Sure, sure.
for
Osama,
Flo?
yes, well, you can also stop your sharing
Sure.
at this stage. First of all, also I congratulate you. So we have lot of viewers now live on Facebook, and many comments from your fellows, from your country, and many other surgeons. Now we have more than 41 questions also on Facebook, and most of them
Oh
are
my God.
yeah, most of them already answered in your debate, and some of them at the end I will highlight. So, what is my question? Because question is this, sir. As you mentioned regarding this redo surgery, and so patients, most of your patients were one anastomosis gastric bypass or single anastomosis gastric by about 400, and also no, I think 300 plus was uh, total 300 plus was redo surgery. So about I think most them like it was 50. If we see 100 was Roux-en-Y, so 200 was single anastomosis gastric. But what is my question? So what was your criteria to do to select the patient? Which patient go for Roux-en-Y? Which patient go for one anastomosis, or no? Randomly you did surgery for these patients.
Uh, as you see here, this study has done between 2009 and 2015, and actually after this data comes on in our practice and after studying this, um we became very careful in choosing the patients, because between 2009 and 2015 we were discussing all the options, and we did one anastomosis gastric bypass for any patient can go for a gastric bypass. If you cannot tailor a longer pouch after restrictive procedures, in a lot of cases like VBGs, we do a Roux-en-Y gastric bypass. So what you can ask me what's happening after this research results comes on.
Sir, no.
Actually,
Why I
now
why I highlight this?
before we don't have characters. We have only that we are going to do in almost in redo surgeries after restrictive procedure. We don't like to make the same mistake, so we don't remove the band and do sleeves. In almost 90% of the cases, we remove the band and go for another mechanism, because restriction has nothing to do. So when the restriction fails, we believe that you have to change the mechanism. So we go for the gastric bypass, and I said to you before, we learn the patients about the one osmosis gastric bypass and the Roux-en-Y gastric bypass, the pros and cons of both, because the patients after failed restrictive procedures, we don't promise him that we will go for one osmosis gastric bypass or Roux-en-Y gastric bypass. So according to the technical data and what we found in the abdomen of the patients, we go for Roux-en-Y gastric bypass or one osmosis gastric bypass. If you have a diaphragmatic hernia, a sliding hiatal hernia, we do Roux-en-Y. If you can tailor a longer pouch, we do one anastomosis. Yet now, after 2015 till now, we prefer to go for a longer PPLM Roux-en-Y gastric bypass than one anastomosis gastric bypass.
Sir, why I am asking this question? Just imagine a patient with this gastroplasty, bending gastroplasty, or this with mesh gastroplasty. That was a previous surgery about 2 decades ago, 15 years ago. So just imagine there is a restriction in the middle of this stomach. So this case is not good candidate for one anastomosis gastric bypass. Definite, we have some restriction in the path. So definite there will be reflux. So another question regarding this gastric bending. Yes, when we will remove this gastric band, and we must do that capsulotomy and also complete release that, and when it will be complete, because 100%, I can ask you, you know better than me this gastric bending, 100% after gastric band they are facing hiatal failure. I am not
Yes,
asking about hiatal hernia, but
yes.
they have, after any type of restrictive procedure, there is some percentage of hiatal failure. So what is my, so if we know what, why we are discussing about this, because this message is going for youngsters. Yes, when we are talking about gastroplasty or the mesh gastroplasty, I agree with you. But when we will talk about a patient with sleeve gastrectomy, patient with gastric bending, if there is no restriction, if there is kink at the side of insula angularis, yes, I will not go for this patient for stenosis gastric bypass. If there is still this, there is functional obstruction of a sleeve or twist, yes, this case is not good, because if you will go, there is more chance. So I agree with you. And what is my question now? Because there is a lot of numbers who faced GERD after redo surgery. Is this GERD was bile reflux or acid reflux? Have you any study?
For sure, when you have very symptomatic heartburn, it's not responsive to medication. I think it's a mixture of bile and acid reflux. So you have concluded very well, Imran, when you said when you have a hiatal failure. If you have a restrictive procedure, you have to expect a hiatal failure. And when you expect a hiatal failure, you don't have to go for one anastomosis gastric bypass. This is a very clear message from myself. I'm responsible about it. If you have a hiatal failure, you should go for diversion. You should go for Roux-en-Y gastric bypass to not face any problems, to not take this patients again after 1 year to convert it to a much more complicated Roux-en-Y rather than the first one. When you have a band, we unwrap the band and we do a complete 360 capsulectomy, and because you will never do a good pouch without unwrapping the stomach. So you do everything, yet you will still have symptomatic patients with reflux after restrictive procedures cause of the hiatal failure. Either you can say twist, you can say narrow incisura, you can say a band, you can say whatever, yet you have to expect the hiatal failures after restrictive procedures.
Sir, I agree. So, but
And it may be not symptomatic enough, and it will be symptomatic after one anastomosis gastric bypass when the esophagus is facing the bile.
sir, I agree. I agree with you. But no, no. But point, which point I want to highlight, because every restrictive case is suffering hiatal failure. Okay. So, but if we exclude that restriction, the distal part of stomach, if we exclude, like if any king, any twist. So, if we, yes, all cases when we do restrictive procedure, there is hiatal failure. This is, there is no debate. But if we can exclude any restriction in the distal part of stomach, then we can go for one anastomosis gastric bypass. Also, we can repair that hiatal hernia. This is my uh, question. Just because mean I cannot ask comment, but
Yeah, we cannot say more than this, Imran. Actually, when you do sleeves, it's a high pressure procedures. Gastric bypass is a low pressure procedure. Are you agree?
yeah, sure, sure, yeah, yeah.
Sure. So a chronic high pressure procedure may end up with hiatal failure. So we cannot promise the patients actually when you do one anastomosis gastric bypass that he will not face reflux. And we cannot also promise the patients if he will undergo a Roux-en-Y gastric bypass that he will not have reflux. Yet in our data, and we have to follow this, follow the science, follow the numbers. In our data, in revisional surgeries, doing Roux-en-Y gastric bypass even after bands and sleeves has better quality of life and less heartburn and regurgitation and GERD rather than one anastomosis gastric bypass, even if you excluded any technical obstructions or twists or something, because you expose the patients with the sleeves, bands, and BBGs to high pressure for a long time. And you don't know what's happening in the hiatus when the patient faced this very high hiatal hernia, hiatal pressure for that long time.
Okay, sir. Okay, sir, please.
So for the safety, we do Roux-en-Y.
Sure, sir. Sir, please share your slides. We can go ahead.
Sure. So for the question that we faced weight regain after one anastomosis gastric bypass, yes, we faced the weight regain after one anastomosis gastric bypass. We faced 37 patients, which is about 1% of our series facing weight regain after one anastomosis gastric bypass. So what we do before the minimizer or the band era, we went for these triple attacks. We decreased the size of the pouch, we trimmed the pouch, we distalize and shortening the common channel, and we narrow the gastrointestinal anastomosis. And from long time ago, 7-8 years, we were doing jejunal sleeve. So we do a jejunal sleeve, we trim the pouch, we distalize, and we undo the gastrojejunal anastomosis and do it much more tighter. And now we use the minimizer, which is a very good option. Actually, we decrease the size of the pouch, and we do we band the pouch, and we distalize and shortening the common channel. This what's happened. So this is the post-operative hour feeding protocol. Everyone knows about this, so I don't think that it's interesting for surgeons. For the question of dumping, actually, honestly, we have no clear data about this issue, but we noticed that it's less than in Roux-en-Y gastric bypass with no need for surgical intervention. Theoretically, the reduced early dumping in one anastomosis gastric bypass could be the consequence of the absence of the root limb or the alimentary limb in this procedure. As you see here in this study of Carl, actually, when he compared the one anastomosis gastric bypass with the Roux-en-Y gastric bypass, we have less dumping. He has less dumping in the one anastomosis gastric bypass patients rather than in Roux-en-Y gastric bypass. So my message, and then we can jump to some videos if you want, like the marginal ulcerations.
Sure, sir. We want to see, and at the end we will hear your message.
Yeah.
We want to show, if you possible, please, your video.
Sure. So we can go for, do you like to see a marginal ulcer patient? This is a marginal ulcer patient.
Sir,
Underwent.
sir,
Do
we
you
can
see it?
see your video. Just first, you can
Sorry.
stop sharing of this one, then we can go.
Yeah, sure.
Now you can share your video. Now screen share.
Yeah.
Yes.
So now this is a patient with asymptomatic reflux, underwent one anastomosis gastric bypass in different center, and this is what we see. We did the endoscopy, and we found an impending marginal ulcer that is about to perforate. And as you see here, when I just grab the loops up, it opens. So, and the patient were had enough with the one anastomosis gastric bypass, so she decided that she doesn't want, she lost enough weight and she wants to only dismantle it and return back to normal anatomy. So what we do is we guarantee the continuity of the loops, as you see here. And I make use of the hanging loops together between each other, and then we close them, as you see. So we guaranteed, we take two sutures and we close the jejunum together, as you see, and then we resect the anastomosis. This is how you, sometimes you find a capacious anastomosis and you can just have a transverse stapler firing and enough space in the jejunum. You don't have to do this this anastomosis. Yet in this case, we had to reverse it, and as you see here, you have to make sure that you don't take any pouch with you. And then, as you see here, we transect the anastomosis, and then you transect the pouch and removing the diseased part with the ulcer. Actually, I had some doubts here regarding the remnant stomach, that it may have any, because we have a very aggressive maneuvers here. So I took another layer securing this part that was facing the marginal ulceration. I've taken it in 2 layers just to make sure that everything is fine. And then we do, as you see here, this is very important, we do a gastrogastrostomy. I can take it back again. We do enterostomy and remnant stomach and gastrostomy. And as you see, between the pouch and the stomach, and then we close them together. We do the all anastomosis with the same techniques, that we take 2-stay sutures and close it. Now we guarantee the continuity of the intestine, and now we guarantee the continuity of the stomach, and we pass the bougie from the pouch to the remnant stomach and do the test, and that's it. This is how we do a complete reversal after marginal ulceration, Imran.
Yes, sir. Sir, excellent presentation. So regarding yes, there are many views about marginal ulcer. If someone is suffering with intractable marginal ulcer, but they don't want to revise completely. So just imagine. So this patient, yes, you did this gastrostomy, and also just you this so just staple this anastomosis, gastrojejunostomy, and completely, yeah, patient weight regain and also other. So if someone don't like to do gastrostomy and suffering with marginal ulcer and intractable marginal ulcer, have you any experience?
Yes, we sometimes do a Ronway, yet we don't go for a sleep for sure. So we do a Ronway. We convert the mini to Ronway.
Rohan bhai. Sir, another option. So, if patient, have you any experience of malnutrition or weight loss, very weight loss? So, sometimes we face, yes, patient is ill, patient is not happy. Maybe BMI is now 26, 27. So, before surgery, it was 60. So, a patient 60 to 27, 28 is also not healthy, looking a little weak, and also. So, have you faced such a case after one anastomosis, gastric bypass, and
Yes,
but
yes, actually, we have faced some cases actually, and what we do, Amran, is as follow. Mostly, the patients that suffering from malnutrition, they want to get rid of the procedure, so you just reverse.
sir,
Yet, if the patient if the patient has an issue about reversal and he wants to be much more healthier and to keep his weight, we may go for proximalization of the gastrogenostomy only. And this happens to us when we do the biliopancreatic limb of 250 and 300 in super obese patients. So we go down to 170, 180.
sir, can you stop sharing?
Yeah, sure.
So why I am asking this question, because the target of this interview, so more one person who is learning more, myself. So because on weekly base, so this is a great opportunity personal for me, because when we face such a case with the malnutrition, patient is weak, there is all elements are low albumin, and there is so many things. So I think 2 3 weeks ago, Mohit also highlight this issue. What he is doing, he is going to do this gastrostomy feeding tube that in the remnant, and they feed the patient. When patient become well, okay, then they will go for surgery or something like this. So after that, when patient is just they resuscitate the patient before going to do surgery, because in such a case, when patient is malnourished, there is some issues. Again, there is chance of leak, so there is chance of leak of that anastomosis. So just this was a comment so from a previous one. uh, okay, sir. Sir, yes. So regarding, so because now really I like to continue this debate, and it was very informative personally for me. And you have lot of questions also from on.
Let me answer this in a minute, Imran. Actually, we have faced some patients with malnutrition who cannot withstand a longer anesthesia, and we have done a gastrogastrostomy above the anastomosis, and we feed the patients orally. And then after 3 4 months, we came in and take the loop down afterwards. So it's a step that could take 10 to 15 minutes in experienced hands, and you can reverse the one anastomosis gastric bypass completely by only gastrogastrostomy. Yet I don't recommend this because you will have a higher incidence of ulceration in the loops. Yet we have done this for 3 4 months. When the patients regain his elements, we came in and take the loops down.
Sir, there are many questions. One question I will highlight. This question is from Dr. Ahmad Bahajat, I think. So his question is about this, sir. What are the causes of stopping weight loss after MGB as revisional surgery post sleeve? So maybe this is a BP limb, length of BP limb. So in redo surgery, especially after a sleeve gastrectomy when weight regain, so definite that BP limb will be different to initial, maybe this question.
Yes, and always in redo surgery, we lengthening the BPLM rather than the de novo procedures. So go higher for more than 200, 250. And actually, a lot of surgeons just transect the sleeve and do a one anastomosis gastric bypass. And this, in our experience, does not work very well. You have to resleeve, you have to enhance the restrictive element in any redo surgery, and you maintain the weight loss with the malabsorptive technique. element. Yet the main player here is to enhance the restrictive element.
Sir, yes, thank you, sir. Sir, a question from India, Dr. Yagnik, also regards to you, Professor Osama. Do you give covering oral hypoglycemic agents for 6 months after MGB for better beta cell reserve in spite of complete glycemic control? You take the question?
Yes, we don't do this. We do a sliding scale and we follow the patient sugar level, and actually they resolve very soon after the surgery. So no, we don't do a single oral hypoglycemic dose. We do this in patients with reliable blood sugar, and that takes time to be adjusted. Yet if the patient shows a very good numbers after surgery, we don't go for any oral hypoglycemic dose.
Thank you, sir. So there are many questions regarding your gastrojejunostomy and everything, because in your debate was clear that was anterior, posterior side. It's a different question. Also, there are many questions about BP limb. Already you have mentioned these, and everything is clear there. And also one of your patient, I think here, and also they respect you, and also so much regards, and the patient is very happy after this surgery. So, sir, we will go ahead. I have one question, because now I take your more time. Because in your presentation, you have mentioned in earlier complication, one of the early complication is bleeding, and also you highlighted what is your message for youngster, what they do so for prevention of this bleeding, like a patient, male patient, central obese, morbid obese, hypertensive. So that MDT earlier you have mentioned. So after MDT, yes, now there is less complication. So other than MDT, yes, control of BP, everything okay. But during surgery, what was my question? During surgery, what they do? They need to, in such a case, need to oversee, need to enhance. What they must do? What is your comment or suggestion?
Actually, we had more bleeding than nowadays. You have to raise the blood pressure of the patient. You have to be, and this is, let me go frankly in this. This is the bad phase of the experience. When you do the procedures in a shorter time, you may have more bleeding. This is our experience, let's say. So please, for all the experienced surgeons, please let your team do the hemostasis, because they are going to do the hemostasis better than you, because they have patients more than you. For the youngsters, actually, you have to keep the patient, flatten the patient. If you just raise the head of the patient, or the upper trunk of the patient when you are head up in the bag position, when you do the surgery, please flatten the patient, deflate the abdomen a little bit, give the anesthesia doctor enough time to raise the blood pressure, put dry gauzes, go for a 5 minutes break and come back and see if there is anything, because when you come back you will find something. Every time you come back you will find something. So take your time, don't rush, don't get rid of the patients early. Take your time, prepare the patients very well before surgery, let your anesthesia doctor in, and give them a big rule in preoperative fitness for the patients. You will find less bleeding for your patients.
Sir, are you recommend in selected cases drain for control of this bleeding?
Actually, we put drains in more than 70 cases of 70% of the cases. We tried everything. We tried without drains. We tried with drains. Actually, putting a drain for 12 to 20 hours after surgery while the patient is hospitalized will do nothing. It will make you expecting any problems earlier. So I don't, I know that literature and publication said that doing drains or without drains, it's the same. Yet we are much more comfortable when we put drains rather than we will not.
Sir, controlling the BP, especially in a patient, hypertensive patient, because after surgery there is a pain and also increasing of this BP. So routinely you suggest so control the BP, which level you control the BP, like 12, 14, 30. This is a hypertensive case with medication.
Actually, 12 is enough. Yet we have a very professional anesthesia team that take caring of the pain after surgery, and we do the PCA routinely for the patients. We exclude only the very severe metabolically ill patients and the elderly patients. Actually, we don't recommend PCA in elderly patients. So and we don't have any problems regarding PPN and pain after the procedures. We encourage the patient actually to take his rule to walk and to get out of the bed 2-3 hours after surgery, and we encourage him to drink very early, about 2-3 hours after surgery, and we give something like a smoothie in the recovery actually while the patient is in the recovery. It's something like a light ice cream or something like that that encourages the peristalsis, and we don't have any problems regarding paralytic ileus or delayed recovery of the intestine after surgery when we do this.
Sir, excellent, really, and it was very informative, practical, really, and also you share your personal knowledge. So, sir, any message for youngsters who are just now going to start MGB?
Uh, Please don't rush. This is my message. Do your one anastomosis gastric bypass. Please attend with seniors and see, because what you have seen from the seniors, it's a vast experience. So you can take the end of the experience. Don't begin from first page, and have more than one procedure in your bucket, and learn and work on your personal skills, know how to do SADI, duodenal switches, one-way gastric bypass, to do a proper one anastomosis gastric bypass. Actually, it is easy as you see it from experienced hands, yet it's really difficult to have a very uniform adjusted one anastomosis gastric bypass. So you have to have a vast of procedures in your pocket, and don't rush, take it very easily, and God bless them all.
Yes, sir, really appreciable. Now, I don't think now here in Dubai is 11:35 p.m. Maybe Egypt also now late time, and it was
Yeah.
great honor for me and for all of us. And you can't believe how much I take messages before your interview and how much these youngsters, especially, they were excited to hear from your side. God bless you, and it was very informative, very practical, and hope this message will go to many thousands of surgeons, because we all are students. We learn till the end, and we must learn from each other experience, and hopefully this platform that GLR provide, especially this weekly interview, will be fruitful for our youngsters. Sir, again, so much thanks for your precious time. And again, I need your support, because we will continue our series, then sleeve gastrectomy, then Roux-en-Y gastric bypass, then redo surgeries, especially. So, definite, we will also again bother you and disturb you in another interview. And it is great honor, sir. Thank you, sir.
It's our honor, Imran, and actually, thank you so much for this opportunity. We missed being together from the year of the COVID, and thank you so much for giving us the opportunity to present our work and our experience. We appreciate the effort that you are doing, and actually, you are my favorite. Actually,
Thank you, sir.
thank you so much, and you have a great night for all of the guys that are watching us, and God bless you.
Thank you, sir, and my viewers. So it was great honor for all of us and great opportunity to have Professor Osama, and we will continue our series of MGB OAGB. Next week, our guest will be from Pakistan, Professor Atif Inam Shami. So he has started MGBOT, original technique of Professor Rutledge, and hopefully his interview will be very interesting, and also his experience in Pakistan. So Pakistan is also part of South Asia, so people have different type of food interest, and so we will talk with him, and also especially this MGBOT original technique for morbid obese patients, and also he will share some complications. Hope you must continue, and this is my just suggestion. So continue to watch our program, and if you have any suggestion, any question, please share with me. Thanks a lot. Have a good night now. Nice time. Thank you, sir.
Thank you.
Thank you,
Thank
sir.
you.
Thanks
Thank
a lot.
you.
Thank you,
Bye
sir.
bye.
Bye
Bye.
bye.